Well, thank you very much, Dr. Lange. That was very helpful. I'm first going to call on Betsy and then Lily.
Thank you very much for that presentation. It was very informative. I have a kind of pragmatic question about neuropsychological testing because, as we know, we're working on clinical criteria and hopefully trying to help physicians find ways to screen patients that are time effective as well, but effective being most important. So my question to you is can you give me an idea of the time frame to do a neuropsychological evaluation that you're describing, the cost, and if you know anything about reimbursement from medical insurance?
Yeah. So the time involved with the comprehensive neuropsychological evaluation I talked about in my practice takes about 8 to 10 hours, which is not something that everybody can do. Neither the cost of a evaluation is something everybody can do. It runs into several $1,000s if the practitioner does not take insurance coverage. Insurance coverage varies. Sometimes it's a regional issue. Sometimes it's better. Sometimes it's worse. Sometimes the insurance company lets you bill for several units of neuropsychological testing. Sometimes they don't. So you can add up. You can end up with perhaps, if you do a comprehensive evaluation of, let's say, 8 hours, plus the interpretation and test writing. So you're talking about a complete effort on the side of the neuropsychologist of about 20 to 25 hours per patient, with feedback and everything. You might talk about reimbursement that ranges from several $100s to multiple $1,000s, depending on whether you're paid by insurance or by the individual. Insurance reimbursement isn't great, and Medicare and Medicaid reimbursement is terrible. So that's why a lot of neuropsychologists are not enrolled in Medicare and Medicaid specifically, which is not good for our patients. To address the question of whether there is anything I can suggest in terms of screening, I know that over the years we've tried to come up with a brief battery to screen ME/CFS patients for cognitive dysfunction. I know that practitioners out there have their own private little things that they use, and some people are very happy with that because it gives them an impression of the cognitive status of their patients. Many practitioners have done this for a long time, so they have kind of they absorbed a feeling of what's good and what's bad. Very few of these batteries are standardized and validated. I personally, if I have to do a quick one-over with a patient that comes in, and if I want to see whether something is amiss in terms of specifically information processing, because that's really the hallmark deficit of the illness, I give them a reaction time task that has been developed for children. And the reason I do that, and that's the Gordon assessment tool that I have in my battery. And the reason I prefer this tool compared to a CPT, let's say, is because you don't have to do it on the computer. It's such a simple, it's a box with a big blue button, and so there is no confusion on the side of the patient with computer buttons, what to hit, getting confused whether it's the D or the F. My patients just have to hold their hand over the blue button and respond. And when I do that, the task takes about, I would say, 15, 20 minutes. I can pretty much tell from experience, but also from the normative data that it exists. And the norms aren't great, I have to say. But I can pretty much tell whether these folks have a problem or not. Whether I would suggest this for a practitioner, for a physician, I don't know.
Thank you for that.
Long answer.
Thank you. I asked the question because I recently attended a session at the IACFS-ME conference given by attorneys who represent patients, and right now they said the most important body of evidence for them to obtain for their clients includes a neuropsych evaluation, the 2-day exercise test, and a tilt test. So that's why I was asking. Thank you.
Hi, Gudrun. Thanks for the presentation. I have two questions. The first is
Yes.
in terms of, like, you mentioned the reaction time, and one of the studies
Yes.
I had read in just doing a general literature review was it talked about how some of the findings on the CFS cognitive were similar to sleep-deprived individuals. So I was wondering, either from your knowledge of the literature or your clinical experience, the pattern of findings you see in CFS, is that different from other diseases or, healthy patients that are like sleep-deprived or have other conditions? That's the first question. And then my second question is, in one of your studies, it was actually two studies, I think you had mentioned it here. And the first study, it was people who said that who didn't perform well on the PSAT, and then you compared them to healthies. And then the second study was people who did perform well on the PSAT but had CFS, and also compared to healthy controls. And I was trying to figure out the logic of that study, why you would use a group that had a similar performance as the controls. Was it to demonstrate that despite the similar performance, they were still having problems on the MRI? That was what I wasn't clear on.
Yes, exactly. Yes. What we wanted to address was the issue of lack of effort. As you probably know, that is an issue that comes up all the time. And it's not the case. And our study shows that it is not. Because the people performed at the same level, yet their brain function was so much different than that of control. So we ruled out that lack of effort is responsible for the increased use of brain resources in ME/CFS.
And how about the first question about comparison with healthy controls and other conditions and other medical conditions?
Yes. Yes. I usually don't see people in my practice that are healthy and are sleep deprived. So I don't feel comfortable answering that. But I do see people in my practice who have other conditions, such as stroke, dementia, cancer, other focal brain injuries. And as I alluded to in the beginning of my talk, the profiles are different. Luckily, in ME/CFS, we rarely see a dementing profile. And the dementing profile is characterized by decreases in particular when you look at the weight score, decreases in the verbal comprehension index. Verbal comprehension index is one of the most resilient areas of cognition. So that is really affected in ME/CFS, and that's a good thing. Language function really affected in ME/CFS, even though people report that they have word finding difficulties. But receptive and expressive language very rarely involved. On the other hand, if you have a stroke patient, language is involved a lot of times, as is visual perceptual function, which is also not involved in ME/CFS. The hallmarks in ME/CFS really are information processing and working memory, with information processing, speed of processing being the number one problem.
This is Ellen. I have a follow-on question to Lily's before I turn to Margarita. Have you done studies in patients who have other disorders such as fibromyalgia and whether they have similar or different patterns? And then Margarita.
Yes, we have done studies in patients that have CFS and FM, and they did, in our hands, they did have similar deficiencies. But other people find that fibromyalgia differs from chronic fatigue syndrome.
My question is in the same line, but it's tied to, I guess my question has to do with how different is it from people having learning disabilities. So for example, some of the, what you explain about having discordant certain tests are very common in people that have learning disabilities. For example, the Gudrun diagnostic test that you mentioned would also come low for people that have attention deficit disorder. So have you tried disentangling how would it differ between a person that has just a learning disability and not CFS and a person that has CFS?
Okay, learning disability and attention deficit disorder are two different things. So as far as attention deficit disorder goes, if you take the DSM-4 criteria, most ME/CFS patients don't fulfill those, because you have to have had that since you were a child, and most of our patients were functioning just fine when they were children, unless you look for adult attention deficit disorder, which is sort of a roguish kind of diagnosis at this point.
No, but
learning disorder.
They changed the disorder, by the way. That they changed that in ADD now. But anyhow, that criteria has gone now. But I'm just mentioning not really in terms of the criteria. I'm talking about the neurocognitive testing. I'm more interested in being able to see the neurocognitive tests and trying to see is there anything like a consistent pattern for people that have CFS compared to like people that have attention deficit disorder, people that might have certain learning disabilities that also show, very discordant difference with the expected intellectual ability.
Yeah, let me think. If you talk about learning disability, I don't think, and that is not my specialty. I'm not doing children or adolescents with learning disability, but I don't see in ME/CFS patients any type of verbal or visual learning disability evidence. They're able to organize visual information. They're able to organize and absorb verbal information properly if given enough time.
Dr. Lange, I want to thank you very much for speaking with us from Japan. I know it's disorienting, or at least it's disorienting for me when I try to do that. So thank you for this very, very helpful discussion and for your making the effort to get up and speak with us. So thank you for doing this. Once again, I want to thank all of our speakers and for all of those who have participated on the internet for this incredibly helpful session. So I was going to say, I hope you all have a nice evening. I hope you have a nice rest of the day, Dr. Lange. And,
Thank you.
and thank you very much. We'll now adjourn.